Okay, good morning, everybody. So this is our third episode of the Happy Hearing podcast. I'm Dr. Ruth Reisman, audiologist and full-time professor at Brooklyn College, and I'm here with my co-host, Carly Sygrove, and my partner, Dr. Janie Morales, as well. So I'm going to pass the mic to Carly, and she's going to just say hi and then introduce Dr. Morales, and we'll take it from there. Go ahead.
Hi, everyone. Hi, Ruth. Hi, Dr. Morales. It's great to be back for the Happy Hearing podcast, episode number 3 today. And so, as Ruth said, Ruth and Dr. Morales are both founders of the same company, which is all about auditory processing disorder. And the name of the company is Urban Hearing. So welcome, Dr. Morales.
Hi.
It's great to have you
Janie.
here. Okay,
nice
Janie.
to be here. Thank you.
So I've got some questions today to ask you. And my main question is actually, what is auditory processing disorder?
Go ahead, Janie. You can take that question.
So auditory processing disorder more has to do with the brain than it does with the ears, right? So in summary, Dr. Jack Katz says it's what the brain does with what the ears hear. Okay, so it's not so much hearing, although people with hearing loss can have auditory processing disorder as well. A lot of times it's the hearing can be completely fine, but yet these individuals still present as though they're having difficulty hearing. So, they can ask for repetition a lot. They can seem like they're completely missing the conversation. So it does present as though there's hearing loss. And a lot of times these kids or adults go in to get their hearing checked as the first step. And the audiologist says the hearing's great, but still that issue exists. So, kind of the concern is that sometimes, especially if it's a child that's being brought in, it's kind of, oh, so you're just ignoring me, or, you're selective listening. And the kid kind of gets like a little, in trouble for it, or domestic deafness if it's an adult. And so it's something that we are trying to bring a lot of awareness to, because just because the hearing is normal doesn't mean that we should stop testing. So anytime we have someone that's presenting with concerns of hearing and they come in and we find that their hearing's normal, we always want to have a conversation about whether an auditory processing evaluation is warranted.
Yeah, I think one of the interesting things that Janie always talks about is the difference between like detection, so detecting that sound is there and sound being audible, versus comprehension, understanding what's actually being said, and all the stages that gets us there, right? So that our system has to be able to pick up the information, and then it has to get processed through the auditory system and at the level of the brain, so that it's not just audible, that like the person's able to hear it, but they're also able to understand what's going on. And one of the very, I guess, easy correlates sometimes, because hearing, as we spoke about last time, Carly, is not always, there isn't always an emphasis placed on hearing as compared to our other senses. So oftentimes they call it like auditory dyslexia. So although the person's able to see and potentially able to detect the different letters, reading becomes challenging. So same thing here, they're able to hear, they can potentially detect the sounds in isolation, but in running speech, when things are less than ideal, the individual is having difficulty comprehending what's being said.
There sounds to be a very close relationship from the outside view here of looking at somebody with hearing loss and then APD. So I'm wondering, for example, somebody like me, I do struggle to process speech. I have hearing loss. How then would you know if I also had APD as well?
So that's a great question, which is why, as Dr. Morales was saying, or Janie was saying, we always check the hearing first, right? So it's difficult to differentiate And there's also other disorders that are comorbid with auditory processing that we can talk about too. But we always have to be able to differentiate, is it hearing loss or is it an auditory processing challenge? So we'll check the hearing, and if there is hearing loss, we ultimately treat the hearing loss first. So, Carly, when you talk about your journey, you tried a hearing aid, you're thinking about getting a cochlear implant. So that's always the first step, is let's treat the hearing loss first. And then when we're testing for auditory processing, everything is what's called supra-threshold, meaning we're presenting it at a volume in terms of testing at a volume that overcomes any hearing loss and that the person should be able to hear. So we're taking hearing loss out of the question. Either they're using their hearing aid, they're using their implant, or we're presenting it loud enough that we're overcoming any hearing loss.
Interesting. So I'm thinking if you're a parent of a child who's maybe struggling understanding conversational speech, or even if you're an adult and having this difficulty, are there any like other key signs that actually you may have APD?
Yeah, so everyone, presents differently. It's kind of like auditory processing disorder, or APD is this umbrella term, right? So there's a lot of listening profiles within that umbrella term. So, sometimes it can be difficulty in background noise. So they can do fine in one-on-one situations, but the minute there's any background noise, they're really struggling. Sometimes it can just be in all situations, where they just always seem like they're asking for repetition or always seem confused. So we do see a lot of times, where there's some overlap, where if they had, let's say, a lot of ear infections, they're kind of a little bit more at risk. If there's any traumatic brain injuries, there's more of a risk factor there. So there's these comorbidities, as Ruth was saying before, which would be like red flags of things that we want to look out for. Do you want to add anything else to that, Ruth?
Yeah, other things like that. Oftentimes individuals with ADHD, because it's more of a global disorder. So sometimes we have to determine, like, is the inattention due to the attention deficit, or is it due to the fact that they're not able to process the sound and they're being perceived as inattentive, right? So differentiating between those two, that's my area of interest or specialty, I would say. Other challenges like autism oftentimes presents with auditory processing challenges. But again, we have to determine, is it that they're not processing, or is it because of the challenges that they're experiencing that they're potentially not focused and things like that. So differentiating between the two is the key. And we have various tests and methodologies to assess for auditory processing in isolation to make sure that it's not these other things that could potentially be interfering.
I was a teacher for 14 years for quite young children. And it's just interesting because a lot of the children I taught, there were many who were maybe diagnosed with ADHD. There were many who were diagnosed with autism, well, some. I don't ever remember anybody saying anything about auditory processing disorder. So I'm wondering, is this something that often goes under the radar?
Yes. Unfortunately, it's really interesting because I'm going to be doing a presentation on for the falls prevention in September. And one of the jokes that I say is, like, audiology is is one of the unknown specialties that present there, and also probably the most underutilized professionals, because we'll get patients like the patient with traumatic brain injury who had an injury 12 years ago, 12 years ago, has been complaining about hyperacusis, which is like sensitivity to loud sounds or sounds in general, has been complaining of processing issues, not only visual processing, but hearing processing. And it wasn't until 12 years later that someone suggested, maybe you should see an audiologist for that. And like he's 32, very young, wants to go back to work. He's been on disability because of his traumatic brain injury. And it's only now that he's finally going back into the workforce that he's, you know, what I would consider hustling, like trying to get it in before the work starts, which is the school year for him and what he does. And I'm just like, I feel so bad that it took 12 years for him to get to us, for someone to say, oh, maybe you should see an audiologist. And I think it's just like Dr. Morales was saying, just a lack of awareness, unfortunately.
Mm-hmm.
So more awareness really needs to be raised of this kind of issue, but support as well that's out there, because you can help.
Right.
For
And
sure.
it's awareness, excuse me, within, you know, the community for audiologists as a whole, right?
Mhm.
So there needs to be even just that, okay, you saw that patient, the patient has normal hearing, let's not dismiss their concerns. You know, if their primary complaint is these are consistent behaviors, right? So you're bringing your child in, or you're bringing yourself in, and you're having these consistent behaviors. It's great that your hearing's normal, right? But then like how like defeating is it to say like, so there's nothing wrong with me? Not like that people want something to be wrong with them, but they know that what they're going through is a struggle, and it doesn't seem like anyone else is struggling. So, you know, to just dismiss that, I think is a big disservice to our patients. So I think there needs to be awareness just within the community itself that there's just too few of us doing the work, and audiologists are the only ones that are able to diagnose auditory processing disorders. So there's too few of us doing the work, but it's you know, we say it's a promising diagnosis because it's something that we can provide treatment for. So it's not that you just have to suffer with this, or that your child has to go through all of these academic difficulties without there being any support for them. And this one patient that Ruth is referring to, you know, it was like this unlikely referral from a physical therapist. You know, so we would think that, you know, if the hearing was tested when the concussion happened, right, or at least if they were even sent, right, which he wasn't sent for any hearing testing. So there was never even the follow-up from the general practitioner. Like there was so many balls that, you know, kind of were dropped or missed opportunities for him to get the help he needed once these concerns were, you know, present for him. So I think just, you know, within the community within the professional community that, you know, that this exists, and that there are people that are, you know, can help. And then within the overall community in terms of parents knowing that this is available. And yes, I think just awareness in general is key.
Must be so relieving for a patient of yours, to actually come to you and realize there's a reason for what they're struggling with, and that actually it can be treated and you can support them in that.
For sure. And to your point, Carly, what you were saying about, like, you know, you worked with these young children and you've never really heard about someone having an auditory processing challenge. Most of the people think that the majority of the patients that we work with are children, because they think this is like a disorder of childhood or something like that. But actually, the bulk of our patient base are young adults. And the reason for that is because they were potentially missed when they were younger for auditory processing, and were given this other alternate diagnosis of ADHD or autism, or just difficulty learning, potentially dyslexia, things like that. And it wasn't until they get to this point now where they're going into college, or they're pursuing graduate level degrees for their professions, where they're like, something is not right here. I see that, although yes, going to law school is difficult, or going to medical school is difficult, like I see myself struggling a lot more than my peers. And I always knew that something was wrong, but, you know, it was never detected or never identified and never treated. We get teenagers that come in that now, you know, their parents want them after high school to get a job in addition to going to college and things like that, but they feel like having this challenge of auditory processing is going to be difficult for them. So actually the bulk of our patient base is these young adults that are going into these life transitions and realize that if they don't get the support, that the next phase is going to be really challenging. So I found that interesting, and because likely when they were in their youth, it just wasn't something that was commonly explored.
And the other thing also, I think, to add on to that is that even within the field of, people that are referring for auditory processing disorders, it's mostly kids. It's mostly kids that are the ones that are being referred, and so it's like you kind of, if you didn't get in someone's, view as a child, oftentimes then there's like I was saying earlier, not so many audiologists are doing this testing, but even among the audiologists that are doing the assessments, it's typically with children. So a lot of times adults that are having these concerns don't really have a place to turn to because they're maxed out, of the age range of, for that clinic, which is unfortunate. But yeah, we definitely see a lot more adults than I was expecting. I thought the population would have been overwhelmingly children.
And if those adults when they were children had actually been recognized as having this, you wouldn't be seeing all these adults. So it's a bit of a circle, isn't it?
Exactly. Completely.
Yeah,
Yeah.
that's definitely interesting.
So are there any, you talked about brain injury, but are there any like common causes of auditory processing disorder?
Yeah, I think there is a range of different things that can cause it. Some of it can just be either genetic or what we would say developmental, right? So a child that just, is born with it, or that the developmental process isn't as robust as other children in their age range or their peers. We did speak about a few other comorbid challenges that can be red flags for auditory processing. So we spoke about attention deficit disorder, autism, and then other things like a history of ear infections, chronic ear infections. So sometimes, people don't think about that as a potential risk factor for auditory processing. They'll say, okay, the ear infection cleared up, their hearing is normal, but then they come out and they still have speech challenges, production of speech, but also, which is usually more obvious to individuals, right? So they'll get speech therapy for the production of sounds, but not realizing that the processing of sounds could have been challenged because of that fluctuating hearing from the fluid. So imagine if the hearing one day is great, hearing the next day is bad. It's an inconsistent message that the brain is getting in terms of sound quality. So that's definitely a risk factor. We spoke about, traumatic brain injuries, falls. There's also another population that we actually didn't discuss. We spoke children, we spoke about young adults, but the older population. So individuals that are experiencing dementia, Alzheimer's. There's a lot of research that shows that if they get treatment for their hearing concerns, whether it's hearing loss, so there's a lot about that, about individuals getting hearing aids to prevent decline and things like that, dementia. But even for auditory processing, even if their hearing was normal, it actually helps to slow down the progression of memory-ish challenges and communication challenges that come along with dementia and Alzheimer's when they get the therapy. So although, and I've spoken to a physician about this because I said, okay, dementia and Alzheimer's, that's like a physiological disorder that we can't necessarily say, okay, we're going to stop it with auditory processing therapy. Like, what is a realistic way to counsel patients to give them realistic expectations? And he showed me the research that just shows we're just prolonging the decline, or supporting the patient even though the decline is inevitable. The communication decline will not be as significant if they undergo the therapy. So the risk factors are throughout the age range, and really anyone who is experiencing these challenges, it needs to be determined whether it's hearing loss, is it, you know, the other comorbid challenges that they're experiencing, or is there an auditory processing and a disorder or challenge in addition to everything else that they're experiencing, where the therapeutic aspect of it can be helpful in reducing the challenges that they're experiencing.
It sounds quite a complex journey to diagnosis. Yeah, did you want to talk a little bit about how APD is actually diagnosed?
Yeah, I can take that part, because Janie and I, we actually work together, and I specialize in the diagnostic aspect of it. And Janie, because she is trained not only in audiology, but also in speech language pathology, she does focus on the therapeutic aspect, although we can fill in for each other when needed. But I'll talk about the diagnostic component to it. So essentially, when a patient comes to us, it's usually like we are the last step, right? They've explored their hearing, they've explored any other challenges that they're experiencing, and we're at the point where, you know, your hearing is normal, or you've been treated for hearing loss, but you're having these challenges. And so we assess, because everything that we do currently with urban hearing is actually a virtual assessment. So it's actually all via telehealth. We assess the patient in 3 modalities. So there's the first portion of it is a very thorough history taking with a number of research-based questionnaires. So we look at the risk factors that they have based on the answers to those questionnaires, and then looking at the history and the intake, and make sure that they've done everything that they need to do before we explore auditory processing as a potential diagnosis. So that's one aspect of it. There's a consultation where we go along and do all of those questions and go through a comprehensive case history. And then there's 2 other components. There's a live exam that we do. So the patient and I are live via Zoom, and we present them with calibrated auditory materials that are specific in diagnosing auditory processing disorders, and not just whether there's a disorder or not. It's also looking at the different categories of auditory processing. So, you know, it's kind of, the analogy is like a bag of Skittles or a bag of jelly beans that are all these different colors, and that bag of jelly beans is auditory processing, but we have to sort them out with the different challenges that an individual can experience. So just for some example, there's a decoding aspect, so being able to isolate the individual phonemes, so hearing the sounds, the speech sounds. And then there's tolerance fading memory, which means talking about the memory aspects. So short-term auditory memory, someone gives you auditory information, how are you able to retain that? The sequencing of information, and then also the tolerance of it, which is hearing in the presence of background noise, or hearing when the acoustic information is less than ideal. So classroom settings, large courtrooms, synagogues, churches, where there's a lot of reverberation. There's a component of organization. So being able to organize the information, the auditory information within the brain. And then there's a component of integration, taking the information coming from both ears and being able to integrate it at the level of the brain in order to process it accurately. So when we're doing that live test, we're assessing all of those components, and depending on the areas of weakness, they get sorted into the different categories of auditory processing. And then there's actually, in order to make sure that the diagnosis that we're making is most accurate, there's also an iPad exam that's done completely independently with the patient on their own. And so we're using these 3 modalities to make sure that if we are diagnosing auditory processing, we are making an accurate diagnosis, because all 3 elements need to match in order for that to say, yes, there is an auditory processing challenge, and these are the areas of weakness based on all three of the modalities that we assess the patient. And then we really take it down to the granular level of, okay, not only is there an auditory processing challenge, not only is there these areas of weakness within auditory processing, but now what are the exact phonemes that they're making, having challenges with. So they're consistently, for example, mixing up P's and M's, right? They're both produced in the same area of the mouth, but auditorily they're not differentiating between the two. They're constantly switching E and I, and we look for patterns like that. Where is the largest pattern? Where is the most significant areas that they keep swapping and making errors? A lot of common errors is adding H's and adding L's into sounds. So just an example, the word was oil and the patient said loyal. And that's very common. For whatever reason, they add an L into it, or they add an H in the middle. And that's also common in individuals that have had a history of ear infections as a child. So it's very interesting. The diagnostic aspect is very comprehensive because we want to make sure, like we said, we're ruling out any other challenges that could potentially be impacting these results. And then that makes it a lot easier for Dr. Morales to develop an individualized therapy plan to actually target the areas of weakness. So Janie can talk about that aspect a little bit more.
You ready?
You're ready.
Always ready.
So Ruth does a phenomenal job by the time I get to the patient. So I really enjoy the work that, the way that we have it split. So as opposed to, you kind of seen, which is nice also to see the patient through the entire circle, right? Where if she did the diagnostics and then also did the treatment, that's great. I think our approach just happens to really suit what we are like the most passionate about. She's an excellent diagnostician. I happen to love therapy. So my background before going into audiology was I was a speech therapist for 5 years, and I worked with children, very young children also. So we probably worked in similar ages. I was with like the preschool ages, and I was exposed to audiology while I was doing, my studies, but not enough for me to want to commit to it. And then, I worked with speech and I loved it. But something always kind of drew me back to audiology. And even within audiology, I've always been very drawn to the therapeutic portions of audiology. So I was very attracted to vestibular rehabilitation, and I got, to do a lot of that, which was great. And then auditory processing, there wasn't a whole lot of exposure when I was doing my my graduate coursework. We did have clinics for it, which was great, but in terms of the placements where I was, nobody was really doing it. So it was something that was always very interesting. I'll keep saying that word, I guess. It's something that always caught my attention, but it was like, well, how do we work with this? And it was always kind of passed along to speech pathologists. And then as I've gotten, more and more into my career in talking with speech pathologists, they're like, well, what do you want us to do with these patients? So there was kind of never this, we thought we were passing them along and they were going on for this treatment. The treatment is very specific to the deficits, right? So earlier, Ruth was talking a little bit about the models of listening. So there's a speech scientist, Dr. Erber, and he came up with these 4 steps, right? So the listening model is you're going from awareness of sound to comprehension, as she mentioned. So awareness of sound, if somebody's not aware that sound is present, we overcome those issues with things like hearing aids or cochlear implants, depending on the severity, right? That last step, which is the comprehension, oftentimes is assumed that if we give you a cochlear implant or we give you a hearing aid, then you're going to understand what's being said. And that doesn't always happen, right? So those two middle steps, you want to be able to, what we're looking at for those two middle steps is discrimination. So awareness to discrimination, you being able to understand or hear the difference, I should say, between a M and an N, right? Or a P and a B. You can hear the difference between P and B, or and N. So not only can you hear the difference, the next step is, can you identify the difference? Can you identify that P is P and B is B? And then that last step is that comprehension. So when we're doing therapy, we're really looking at where in the system was the breakdown, right? She gives me this great phonemic analysis of all of the errors that were present within the testing. So there's she goes through each of the responses, and was it a substitution? Was it an omission? Was it an addition? What exactly did they do to get to the word that they came up with, right? And all of that information is really helpful because it helps me to say, okay, what are the sounds that are the most problematic for this patient? And let's really focus on those first. Because therapy, we're building up each week. So every week that we go into therapy, we're reviewing the week before, right? And then, so by the time we get to, the third week, now we're reviewing weeks number 1, weeks number 2, and introducing the new material for week 3. Our therapy is broken down to, we call a round of therapy, about 12 to 14 sessions. So it really is based on the progress for each patient individually. Some patients end at 12 sessions, some patients go on to the 14 sessions, but around that 12 to 14 mark is on average where we complete that round of therapy. Within the therapy, like I was saying, is that it's very deficit based. So, those sounds where they're having the most trouble with, they're getting that review for, by the time that 14th week comes, now they've really, it's a lot of drill work with it, right? And we do everything virtually, which is nice because everyone's in the comfort of their own home. So, in terms of the setup for that, it's usually I block off 1 hour. So the patient can choose, on their schedule based on my availability. And we meet together for 1 hour every week consistently for that 12 to 14 week session. And then once therapy's done, I do also assign homeworks, right? So they do just some carryover practices assignments throughout the week. So we do an hour of therapy live. And then I also send some links, and they're, fun games that they basically play just to continue to reinforce what we were working on. And then those, I try to have my patients do those about twice during the week. Just so that way there's just that rote memory. You just want to keep exercising that muscle, right? And just keep practicing those skills. So, by the time I see them, the next time, they would have already done 2 kind of, review sessions on their own at home. And then I see them again. And so once we're completely done, about 2 to 3 months later, they see Dr. Reisman again after we've completed our therapy. And then she does that reassessment, which is the same assessment that she did the first go. She does that reassessment, and then we have some really good data to show the patient, this is how you were performing before therapy, and then these are the results after therapy. And that is really powerful to see.
Wow, there's a lot of steps involved there, and lots of things to work on, but it all sounds very doable, and it all sounds, you said you give them games, you do nice activities. It all sounds actually quite fun. Mm-hmm. And I'm thinking, if this had been, a child, when somebody was a child, and it was just 12 weeks of this could actually be helpful. I mean, so easy to do.
Right.
Mm-hmm. Yeah. And the prognosis, like Janie was saying, is just so positive, because more likely than not, everyone is going to get benefit and is going to improve. Yes, we do have those cases where it's like a patient goes from an impaired test to completely normal, which is fairly common. But, when there are multiple challenges, so yes, even going down to 50% of the errors that they had initially is a huge win, and can be seen even in their day-to-day life. We had a couple that the partner started to realize that her partner was doing so much better, and she's like, maybe I have these issues too, let me get checked out. And she saw like the benefit of how his communication was improving and things like that, and said, maybe I have these challenges too, I should get that explored. So it is really interesting to see not only the data, like Dr. Morales was saying, but also the impact that it has on their lives. And we have lots of stories like that. So it's definitely very rewarding.
And recently, not a few months back, a patient shared with me that she is a recovering alcoholic, and she said, I honestly, in looking back, I think that I drank because it was like a self-soothing, it was a way to cope with her difficulty being in a bar, being in an environment where she felt she was supposed to be because that's what her peers were doing, right? And she just never enjoyed background noise. She couldn't tolerate it. It was not where she wanted to be. And so she used drinking as a way to kind of get through that. And it was so interesting to see that she had she thought and said, I think if I would have had this resolved, if I would have done the therapy and would have been able to tolerate the environment, I wouldn't have needed to use alcohol as a way to get through it. And that when I remember after that patient, I contacted Ruth, and I was just like, oh my goodness, like that was, that's an extreme, case in a sense, right? That's not like, everybody's doing something that, to compensate for these skills, like that's the negative thing. But in her case, I think it made such an impact on her that she just feels like, no, I don't need to. I mean, she didn't quit drinking because of therapy. She had already become, sober. But it was such an eye opener, I think, for her to share that with me, to see how impactful this can be and what a quality of life it really, the improvement on the quality of life is. It's making such an impact. It goes beyond just the academics. It's just day-to-day function. When people are uncomfortable in their listening environments, everything is kind of dependent on that, right? So it's an active skill that when you struggle with just the basics of day-to-day functioning, you're using so much more energy and so much more, you're just so much more exhausted to get through what everyone else seems to do seamlessly. And that's really where we're seeing that big difference, is the quality of life. Yes, academically with the kids that we're seeing, with the adults that are going into their careers, we definitely, are hearing great stories, but it just seems like the overall improvement on just day-to-day function is really what's making the biggest impact for these patients.
Like you said about this, the case study you just shared, it's those social situations. Social situations always have noise. They have background noise. You've got people talking in the background. You might have music. It's difficult. And I can see that similarity between hearing loss and auditory processing disorder when you tell stories like that, because trying to listen over background noise is so difficult. And it seems like for people with auditory processing disorder, it's just as frustrating because their brain actually can't understand that what's being said. So I can completely see why, I can understand this patient's story from my own point of view.
Yeah, there's a lot of correlations in the function in terms of like having hearing loss, even when the hearing is normal. So you're right in saying that, Carly, for sure. So I think we did cover a lot today, and I really wanted to enhance the understanding of auditory processing. And Carly, you were great in asking the questions, and it's good to have a blank canvas to be able to chat about this. And we spoke about what are the risk factors. We spoke about how it's diagnosed, how it's treated. And because it is still an area of a lot of exploration, there's a lot coming in the future, Dr. Morales and I are going to be involved in a couple of potential research studies and things like that will be able to give access to our patients to that and all the future of technology that's involved in this. So we're really excited about that. And, if anyone who does have any concerns or feels like they have family members that are concerned, they can always feel free to reach out to either myself, to Carly, to Dr. Morales, and we're really happy to explore that and help navigate the journey if needed.
Mm-hmm. Definitely. Anyone who ever wants to reach out, I'm always happy to connect. And I can forward people onto Dr. Ruth and Dr. Morales as well.
Thank
Sounds
you.
great. Okay, thank you both. Have a great day, and it's been another fun episode. Looking forward to our upcoming episodes. We have some interesting stuff in the works, and excited to present that to everybody.
Thank you. Bye-bye.
Bye. Have a great day.
Bye-bye.